Good evening everyone and welcome to tonight's flu vaccination and Zostavax update. My name is Penny and I'm your host for this evening. Tonight I'm joined by our facilitator Dr Tim Senior and presenter Dr Vicky Sheppeard. Before we begin, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. I'd like to introduce our presenter for this evening, Dr Vicky Sheppeard. Vicky is a public health physician who has been working for New South Wales Health since 1999. Vicky's current role is Director, Communicable Diseases Branch, Health Protection, New South Wales. This role includes overseeing surveillance of notifiable diseases in New South Wales, coordinating communicable disease control activities, oversight of immunisation programs, including delivery of the school-based adolescent vaccination program, and representing New South Wales on Communicable Disease Network Australia. Previously, Vicky managed health protection services in the Nepean Blue Mountains and Western Sydney local health districts from 2008 to 2013. And welcome, Vicky.
Thanks, Penny.
And our facilitator for this evening, Dr Tim Senior. Originally trained in the UK, Tim is a GP at Tharawal Aboriginal Corporation in southwestern Sydney. Tim is also the RACGP Medical Advisor for the National Faculty of Aboriginal and Torres Strait Islander Health, a senior lecturer in general practice and Indigenous health at the University of Western Sydney, and is a medical educator here at the New South Wales and ACT faculty. And big welcome to Tim.
Thank you very much.
There he is.
I think I'm unmuted now, yes.
Are unmuted. Welcome tonight. I'm going to hand over to Tim now, and he will take you through the learning outcomes for this evening's activity.
Yep, so the learning outcomes will be coming up on the slide here, and that's really that's educational speak that at the end of the activity, this is the sort of thing that you should be able to do. So at the end of tonight, you should be able to identify which conditions are contraindications for Zostavax, and we'll go through that, and that's very important. Be able to recognise the contents of the 2017 influenza vaccine and which formulations are available for particular age groups. We will be able to plan in our own practices to maximise the uptake of influenza vaccine in eligible groups, and we'll be able to utilise resources to obtain current information on influenza activity. So that's what we aim to get out of tonight. And so we're going to start off with the Zostavax update, and I'll hand over to Vicky just to talk about this. Feel free to ask questions using the question box as we go through if anything's not clear.
Great, yeah, thanks Tim, and good evening again to everyone. We thought we'd put this reminder in here tonight. We did a comprehensive webinar on Zostavax back in November, and Penny will post the links to that later. So what we hope to achieve tonight is to really just go over some of the key issues that are happening about the implementation of this program, and in particular contraindications. So I'm sure you're all aware that Zostavax has been on the NIP since November 2016 for people aged 70 years of age, and we've got a 5-year catch-up program for those up to 79 years of age. And I'm sure many of you will have been frustrated by the vaccine supply restrictions that have been in place, and we're going to face that for another few months, unfortunately. And this is because the manufacturer hasn't been able to supply enough to the Commonwealth to meet the demand that we've had across the country. We've recently looked at our numbers in New South Wales, and we will be relaxing a little bit, but there will still be upper order restrictions in place, at least till the end of July. And we'll let you know through the online ordering system once that frees up. But I guess the key features about Zostavax is that it's a live vaccine, and it's got 14 times the concentration of virus as the varicella vaccine. So this makes it a challenge. It's because it has to have that much virus in it, because its aim is to stimulate the cell-mediated immunity of older people, and as we know, your immune system becomes a bit sluggish as you age, so you need a big dose to be effective in this age group. And we can administer on the same day as other live vaccines, although other live vaccines are very rarely used in this group. So the example we're giving here is yellow fever, but really that is contraindicated in this over 70-year-old group. But if you were giving another live vaccine to this age group, it could be given on the same days. But really importantly, and with our flu season coming up and you have elderly people coming in for flu vaccine, it's fine to give it on the same day as inactivated vaccines. The aspect of Zostavax that's concerning us most, and I hope you've all received alerts about this, is we've had a death in New South Wales of a patient who was given Zostavax, who had chronic lymphocytic leukemia and died of disseminated Zostavirus infection a little over a month after he'd received the vaccine. I haven't put the details of his case in this presentation because that's still being worked through, but there was a very similar case in the United Kingdom, and that has been published. So I'll just briefly touch on the key features of the United Kingdom case, and some of those are shared with our local death. So in the United Kingdom case, it was a 79-year-old man with chronic lymphocytic leukemia, vaccinated in October 2014, and 2 weeks later developed flu-like symptoms, and a month after the vaccination presented with fever and a widespread zoster rash. And despite being commenced on acyclovir intravenously, he developed respiratory and renal failure and multi-organ failure and passed away from this infection. In this case in the UK, the vaccine strain of varicella virus was detected in the vesicles from his rash. And so, this was a person who hadn't received immunosuppressive agents for 6 months prior to vaccination, but chronic lymphocytic leukemia, lymphoma are all contraindications to vaccination with Zostavax. So, Tim, I thought it was important that we just go through that and reiterate these contraindications to our colleagues.
Yeah, and I think because we have had a case in New South Wales, so I think it's important that we all remember the contraindications. And the other important thing, I think the next slide's coming up, shows what those contraindications are. But the other important thing is not just ourselves remembering them, all our memories are fallible. It's what the systems we have in our own practices that will minimise the risk of anyone with contraindications being given the vaccines, whether that's notices on the fridge or ensuring that our practice nurses know the contraindications and that we're checking for those each time we give it. And I think all of us will have ways in our practices of doing that, and it's worth reminding ourselves and thinking of how we're going to do that in our own context, I think, as we go through this as well.
Yeah, so Tim, you were talking about having systems in place about not inadvertently vaccinating people who are contraindicated.
Yeah, that's right, and having systems in place in our practices to ensure that it's not just reliant on our individual memory, but that we know that we're checking each patient and then our practice nurses know, so that we're not accidentally giving to patients with contraindications.
Yeah, so just to run through the contraindications, and we did talk about these last time, and they're certainly in the important to check the online version of the Australian Immunisation Handbook, and also some very good fact sheets that the National Centre for Immunisation Research have published, and Penny will give the links to all those. So high-dose immunosuppressive therapy, so either chemotherapy, radiation therapy, higher dose oral corticosteroids, and we've got a table in the next slide to look at the doses of those agents. And then any malignant conditions such as lymphoma, leukemia, Hodgkin's disease, HIV infection, particularly those with low cell counts or high viral load. And then people who've had solid organ or bone marrow transplants in the past 2 years, or those transplant recipients who are still taking immunosuppressive drugs, and then anyone with a similar level of immunocompromise to that.
We've just had some questions come through as well, which are worth looking at. Can women on anti-estrogens for breast cancer have Zostavax?
Well, that's a very good question, and I think so, because that's not an
yes.
But
yeah, my impression would be as well that I think they probably can.
And some of these questions are about the dosages of corticosteroids, methotrexate, and others. So
that's right.
The table that Penny's got up now. So this is a fairly simplified table. So prednisone less than 20 milligrams a day for less than 14 days is okay. But of course, there's many combinations of steroids and prednisolone and other formulations. So what's happening at the moment, and in response to this incident, the National Centre for Immunisation Research are looking at a much broader range of potential combinations and formulations of steroids, and we'll be coming out with more definitive advice around these grey areas. But I guess for the moment, if someone is on a dose of immunosuppression that is higher than any of these here, or potentially higher, or if they're on more than one immunosuppressant, then really the precaution is not to vaccinate until you've at least spoken to the supervising specialist. I think we had a question before about methotrexate as well, and the dosage is on this table.
That's right.
The acceptable dose of methotrexate.
We've got a couple of people asking about hepatitis B and hepatitis C, and whether that's a contraindication.
No, Tim, I don't think that is. So, we've been really about immunosuppression. So those aren't immunosuppressive conditions.
Yeah, absolutely. And someone else asking about if people have had a previous diagnosis of lymphoma or leukemia in the past, would that be a contraindication to Zostavax?
Well, certainly any chronic leukemia, or because really those are lifelong conditions, and prior acute leukemia I think would be acceptable, provided their hematological markers were within normal limits. But any prior lymphoma I would be very cautious and err on the side of not giving. And there was a question here about prednisone and methotrexate together for rheumatoid arthritis. And again, I would not go ahead and vaccinate a person on that combination of immunosuppressants without seeking advice from We've got a couple of options: the New South Wales Immunisation Specialist Service, or the treating specialist of the patient.
And someone else asking about Leucrin for prostate cancer, which is an anti-hormonal rather than immunosuppressant. So I'd imagine that it's okay for use in that.
Yeah, again, as it's the immunosuppressant aspect that's of concern. So, so we've got hematological malignancies or immunosuppressants, but so solid organ tumours and non-immunosuppressing treatments of them are not contraindicated.
And someone's asking, what should people over the age of 80 do? But the vaccine actually indicated for people over 70, and the older people get, the more at risk they are. Is that right for serious Zostavax infections they require admission more frequently? Is that right?
Well, yeah, we had a slide about this in the November webinar, Tim, and by the time someone gets to 80, the effectiveness of Zostavax in preventing shingles is down to about 18%. So has a very low value in preventing shingles. It does have some value in post-herpetic neuralgia in that group, but certainly on a population basis was not considered cost-effective. So I think discussing with the patient, they would be paying for the vaccine, and the likely benefits that they would get from it would be an important discussion to have.
Yeah. Now we've still got questions. What I'm suggesting, I think, because I'm just aware of the time and we've got the flu vaccine things to go through, I think it's probably worth seeing if we can tackle those questions by email afterwards, if people still have questions about particular contraindications.
Yeah, sure. Very happy to do that. Well, this slide now is basically what we've been saying. If there is uncertainty, it's better to defer and seek specialist advice for these patients in the grey area. And Penny will post the...
I've actually in your control panel, there's a handouts pane, and I've put together a document with all the links that that we mentioned in the webinar in that pane. So you just download those documents and then you'll have them rather than trying to grab them from the chat log.
Okay, easier. Thanks, Penny. And then the final slide about Zostavax was, what if you have given it and you go, whoops. So, yeah, I think the first port of call is to speak to the patient specialist and discuss whether or not antivirals, acyclovir or famciclovir, should be commenced. But another point of call, if you're not confident or with the advice you've received from the specialist, because we have had circumstances where some specialists haven't been as familiar with Zostavax as we would have hoped. But the New South Wales Immunisation Specialist Service is also available during business hours. So those are the experts at the National Centre.